Namaste to all of you. எல்லாருக்கும் வணக்கம். This is Dr. Suresh Anand, consultant breast surgeon in Triple M Hospital. I am making this short video as requested by Dr. Jayashri, lactation consultant. This is for all the mothers who are just delivered or a few weeks after delivery who are having some feeding problems and to educate them about the possibility of breast infections, how to prevent them, how to recognize them if we have an early infection, uh, and what to do if you think that you have any breast infections. Okay. We've started a breast clinic in Triple M Hospital in 2008, and we see almost every 1 to 2 weeks there is a person with breast infections. Two-thirds of these infections happens in people who are breastfeeding, and especially it is the firstborn primiparous ladies who have breast infections. 65% occurs in the firstborn, and majority of the goes on smoothly. It is, but maybe people who are at risk of getting breast infections are those with latching problems, who have got feeding difficulties. This happens in especially mothers with the flat nipples. Because how does a breast infection actually develop? You see, it it happens because of improper latching of the baby. So if let us say there is a flat nipple and the baby tries to latch onto the nipple, but is not getting a smooth flow of the milk, in which case it gets very irritable and starts to nibble on the nipple, which produces the crack in the nipple. And as you all know, the half the cells in the body are bacteria. The bacteria is there in the skin and also in the mouth. So once the defense mechanism, which is the skin, is breached, bacteria can enter through the nipple. So, and it is from the baby's mouth. If the bacteria enters into the crack, it can produce an infection of the duct. There are about 15 to 20 duct systems through which the milk comes and converges onto the nipple. So it usually can go and infect one or two duct systems. And that is called as a mastitis or an early stage of infection. Now, it's a common mistake what I see is people are not able to recognize that there is infection because they feel there is engorgement and there is pain and they attribute it to a blocked duct, but they do not recognize that there is a possibility of infection. So how do you know whether you have just a blocked duct and just an engorgement, which can be treated with hot water compresses and cold cabbage leaves? The most important are four signs of infection. Number one and most important is fever. So if you are breastfeeding and if you have fever, that means 100% there is an infection. Second, there will be a lump if there is an infection, and usually it will be firm to hard. The majority of these lumps happen around the areola. The third sign is redness. So if there is redness of the skin, that means there is likely to be infection. And fourth is pain and tenderness. So over the lump, there might be severe tenderness. If you have these are what we call signs of inflammation or infection. So if there is fever, lump, pain, and redness, that means this cold cabbage or hot water compresses is not going to help. It is going to require antibiotics. So what do you do if you have a problem, you have a cracked nipple, and you have a fever? Who do you contact first? I would say the first port of contact will be the lactation consultant or the obstetrician who has delivered. So if the lactation consultants or the doctor feels that there is a possibility of infection, what do we do? If it is a very, very early stage, like only 1 or 2 days of symptoms, then you can be straight away started on antibiotics. And the commonest antibiotics is co-amoxiclav, 625 milligrams twice a day. Usually it's given for 5 days or sometimes 7 days. But if there is a definite evidence of lump, with fever, then you need a um, ultrasound scan of the breast to see whether there is a pus collection or not. Because it progresses. Once the bacteria starts multiplying within the breast, it then soon forms an abscess or a pus collection. And that pus has to be drained. Antibiotics alone is not sufficient once you have a collection of pus. Otherwise, you would be getting what you call an antibioma, which is a solid lump in the breast, which will stay for months together. So the simplest thing to do is get an ultrasound scan, and if you chose a collection, you don't need anything else apart from aspiration of the abscess under ultrasound guidance with local anesthesia, which hardly takes 2 to 3 minutes. It's such a simple procedure, outpatient procedure, very cheap, and we just send the pus for microbiology lab to see what bacteria it is, and we'll get the report in 48 hours, and you can be started on antibiotics. In our data, we about 48% of this bacteria is usually a simple bacteria called MSSA or methicillin sensitive Staph aureus, which responds to a simple co-amoxiclav. The 44% in our practice is due to another bacteria called MRSA, methicillin resistant Staph aureus. This will be resistant to co-amoxiclav, and that is usually sensitive to an antibiotic called linezolid, which is the only tablet form which is available. The rest of the treatment for MRSA is all injections like vancomycin. So it's very important that if you have signs of infection, that we recognize it early, because if we give the antibiotics, it will disappear within a few days time, and you can continue with breastfeeding. There is going to be absolutely no problems afterwards. But if it is not recognized that there is infection, and if there is a delay, it usually progresses to breast abscess, and that is usually what we see in the breast clinic. Yeah, it's amazing. People come after 1 week of symptoms or 2 weeks of symptoms with a large breast abscess with 100, sometimes 200 ml of pus. I'm amazed to see how these people have been missing the breast infection. They've been treating it with hot water packs and compresses. My mother told this, my grandmother told this. All the stories usually come. Understand that if you have an infection, if you have signs of infection, it requires antibiotics. So once we know that there is an infection, there is a collection. Majority of the hospitals still go for open incision and drainage, which is a surgery where you need a general anesthetic, and then we have to make a nick in the skin and drain all the pus and then pack it till it heals, which might take like 2 3 weeks. Sometimes there is a risk of milk leaking through the incision. That's called milk fistula. So actually, we do not need to do this. The simplest way of treating this is a ultrasound guided aspiration of abscess under local anesthetic. And we just aspirate, even if it is 100 ml of pus or 150 ml of pus, it can be aspirated under ultrasound guidance. The pus can be sent to the lab for culture. We can know what bacteria it is and the sensitivity of the antibiotics in 48 hours. And you might need repeat aspiration 2 or 3 times. If it's a large abscess, even about 5 6 times. But it 100% it will subside with antibiotics and aspiration, and you can also continue to breastfeed on the side. The only contraindication is if there is pus discharge from the nipple, then you cannot directly feed. You will have to discard that, express it, and discard the milk which is infected. Uh, there is no contraindication for stopping breastfeeding. You can continue to breastfeed. That is the point. A small portion of patients will present with the pus almost coming close to the skin and ready to burst. That's called as a burst open breast abscess. Even in that case, you do not need to do open incision and drainage. You can just put a local anesthesia and make a small nick over the thinned out skin and continue to aspirate the pus under ultrasound guidance. So I would say in our practice, 98% of all this breast abscess is subsided with ultrasound guided aspiration of pus and antibiotics. And you can continue to breastfeed. In case you had an open incision and drainage, and if it is close to the nipple, then it will be difficult to feed, right? Because the baby cannot latch on to, should not be in touch with any wound or any pus or blood. So the only contraindication to breastfeeding is if there is a pus coming from the nipple or if there is blood coming from the nipple, in which case you'll have to express and discard the secretions. The other thing you need to take care is you need to lubricate the nipple with the nip care so that it is not too dry. The commonest problem is actually flat nipples. So this is where a lactation consultant can help you. See, there are different techniques of getting a good latching positions for the baby, and I hope that nobody gets infection. But don't worry, if you have any signs of infection, please go to your lactation consultant or your obstetrician early because you need antibiotics. Okay? If there is a delay in starting antibiotics, then it can progress to form an abscess, which is very painful. And I've seen people go into even postpartum depression with this. So, but even if it is there, don't worry, we are available here. So we can easily aspirate the pus and treat it easily. You don't have to worry. You enjoy your motherhood. Okay, all the best. Okay, namaskar.